Okay.
Muy buenos días, tengan todos ustedes. Sean bienvenidos a la clausura del Congreso Mundial de Neurocirugía organizada por la Walter E. Dandy Society en conjunto con la UNESCO y nosotros como Asociación SAIN México. Soy médico paciente de Servicio Social Diego Alberto Sandoval López, soy miembro de la Comisión de Investigación de SAIN Chapter México. En representación de la Walter E. Dandy Society, queremos agradecer al embajador de la PAE UNESCO, Jorge Herrera Ramos, presidente del Congreso Mundial, por la organización de este evento, así como al compresidente Prof. Salem y Abdul Rauf del Instituto de Neurocirugía, fundador, presidente del Departamento de Neurocirugía de la Universidad de St. Louis University, Missouri, en Estados Unidos, presidente global de la Walter E. Dandy Neurosurgical Society, 17º presidente de la Sociedad de Brain Mapping and Therapeutics. También queremos agradecer a la doctora Dayanira Casillas, presidenta de la Student Chapter AANS IPN, Vice Chairman del World Congress de Neurocirugía, al doctor Babak Kateb, presidente de la Society for Brain Mapping Therapeutics, Brain Mapping Foundation y vicedirector del Congreso. Y finalmente a los directores honorarios del comité, profesor Nasser El-Gandour y profesor Marcus Rota. Es un honor participar en este evento. Tengo el honor de presentar al doctor Calvin Mak, es adscrito del Departamento de Neurocirugía en el Hospital Queen Elizabeth en Hong Kong. Tiene múltiples publicaciones en un rango extenso de temas, entre lesión cerebral traumática a gliomas. El tema del día de hoy es cirugía endoscópica extensiva de base de cráneo. Good morning, welcome to the closing of the World Congress of Neurosurgery, UNESCO, in collaboration with the Walter E. Dandy Society in honor of the Professor Casey Yazargil. I am Diego Sandoval, a member of the Research Commission of SAIN Chapter Mexico. On behalf of the Walter E. Dandy Society, we thank the Ambassador of UNESCO, ASP.NET, Jorge Herrera Ramos, Chairman of the World Congress, for the organization of this event, as well as the co-chairman, Professor Salem E. Abdul Rauf of the Institute of Neurosurgery, founding chairman Department of the Neurosurgical Surgery, St. Louis University, Missouri, in the United States of America, global president, Walter E. Dandy Neurosurgical Society, 17th President, Society for Brain Mapping and Therapeutics. We also want to thank Dr. Dayanira Casillas, President of the Student Chapter AANS IPN, Vice Chairman of the World Congress of Neurosurgery, Dr. Babak Kateb, President of the Society of Brain Mapping Therapeutics, Brain Mapping Foundation, Vice Chairman of World Congress, Honorary Chairman and Committee, Professor Nasser El-Gandour, and Professor Marcus Rota. It is an honor for us to participate in this event. I'm honored to present Dr. Calvin Mak, Associate Consultant in the Department of Neurosurgery at the Queen Elizabeth Hospital in Hong Kong. He has several publications in different range of topics, from neurosurgery, from traumatic brain injury to gliomas. Today's presentation is about extended endoscopic skull-based surgery. Thank you very much, Dr. Calvin.
Hello, thank you for the very kind introduction, and good morning, everyone. I presume it's morning for the majority of the audience. So I'm Dr. Calvin Mak from Hong Kong. I'm a consultant neurosurgeon from the Queen Elizabeth Hospital, and I'm also the honorary clinical associate professor from the Chinese University of Hong Kong. So today my topic is on endoscopic transorbital surgery to the skull base and orbit, which is, I would say, a very fascinating topic. It's quite new if you look up into literature. And so I will go through this and hope you enjoy the lecture. So just to start, this is where I come from. This is my hospital, Queen Elizabeth Hospital. It is located in Hong Kong. So if you ever have the chance to visit Asia, you must have heard of Hong Kong, a beautiful city. And this is where my hospital is located, in the center of Hong Kong. So it is one of the largest neurosurgical units. It's a tertiary referral center in Hong Kong, receiving a lot of different types of patients, especially in skull base as well. No conflicts of interest to declare. So let's go straight away. So I believe most of you must have some understanding of the basic anatomy of the orbit. So basically, it is made of different pieces of bones that is actually just closely associated with the skull base and the brain. So this is the right side. This is where the surrounding structures are. Laterally, it is the temporalis muscle. And inferiorly, it is the maxillary sinus. Medially is the sphenoid sinus, and superior medially is the frontal air sinus. And more interestingly, importantly, is actually it is closely associated with the skull base and the brain as well. Superior to the orbit, it is the anterior cranial fossa base, where the frontal lobe is. And just posterior to it, it is the middle cranial fossa, where the temporal lobe is. So it offers a very good window to the access to the brain and the skull base in actual fact. So take a look at this diagram. This is the view from the front, from anterior, that we are able to see the carotid artery on the right side and the left side here. Okay, and this is the optic chiasm and the optic nerve. And you see there are a lot of cranial nerves just lateral to the internal carotid artery. And here in the middle is the sphenoid sinus. So if there are lesions just located around the cavernous sinus or the orbital apex or the base of the middle fossa or the anterior cranial fossa. So traditionally, we go from above. That is craniotomy. So this is what traditional neurosurgeons we usually do, and we still do it every day for different pathologies. It is very versatile, but then it is quite invasive. Imagine you have to make a big scalp incision and then to take a bone opening, a big opening, just to remove sometimes a small lesion, say for example, 1 centimeter or 1.5 centimeter. It's a big hassle and will cause a lot of morbidity to the patient with the scar and the muscle atrophy and pain, etc. So there are new techniques in the past decades, actually, that go from the nose, the endoscopic endonasal approach. So it's going from below, from medially to the cavernous sinus region and to the skull base. It has the advantage of being minimally accessed, but it's actually not really entirely minimal invasive because when we go from the nose, we actually need to take out a lot of the structures within the nose, which can cause a lot of nasal mobility as well. And what's more, imagine if the lesion is located lateral to the cavernous sinus and the carotid artery, then going from medial, it requires crossing the cavernous sinus, the carotid artery, and also the nerves in order to go to a lesion lateral to the cavernous sinus. So it is not a very good way to tackle lesions at this area. So therefore, here comes the endoscopic transorbital approach, which because the orbit is actually just located lateral to the carotid artery on both sides. So it offers a direct and anterior access to the lesion located just lateral to the cavernous sinus and the carotid artery. So here comes the term tones. Transorbital, T-O, transorbital, N, neuro, E, endoscopic, S, surgery. Transorbital neuroendoscopic surgery. This term actually first described by Mo in 2010 in the publication, which offers the advantage, as I said, it's a minimal access and minimally invasive because you don't really need to take down a lot of structures. I'll explain to that later. And in actual fact, it is by performing a craniotomy, that is opening the hole in the skull through an orbitotomy to the skull base. It offers a direct and anterior approach, and it utilizes the advantage of it being the corridor lateral to the ICA and the cavernous sinus. So this is the right eye. So there are different quadrants. We divide it into 4 quadrants. Superiorly, it is through the superior eyelid. Laterally, it's a lateral retrocanthal that is just behind the canthal ligament. And inferior is a preseptal approach, and medially is the precurruncular approach. So imagine by going through the eye, okay? I mean, not through the eye, but through the orbit, what can be done? These are the anatomical studies that have been described by different authors, from amygdalo-hippocampectomy to optic nerve decompression, to different structures in the skull base, like the Meckel's cave, lateral cavernous sinus, and intradurally, amazingly, you can reach the optic carotid cistern, the Sylvian fissure, where you can clip an aneurysm theoretically, to the petrous apex, which traditionally it requires a Kawasi's approach by a petrosectomy. And what's more, we've discovered in the lab, we can actually reach the infratemporal fossa. So how we do it? So first step, we approach by an incision over the eyelid. Okay, there are different approaches. I'll just focus on the simple ones. So the most frequently used is the superior eyelid incision. Okay, and then we go all the way to the periosteum. This approach we usually do together with the ophthalmologist. We have a good team in my hospital, and we collaborate each other during the surgery. And so the incision is going deep to the periosteum, and then we do a subperiosteal dissection. Alternatively, sometimes we use a subbrow incision. That is, we don't do the incision over the lid crease, but we do it over the eyebrow, so a little bit superior. The advantage is that it is more familiar with neurosurgeons, and it has also the versatility to remove the orbital rim, which can give some more surgical freedom during the dissection. So this is the incision in real patients. So this is the incision. This is over the eyelid for this case. And then we remove the part of the orbital rim here. You see, it's a very small bone, a small piece of bone. Imagine, just to compare that with a craniotomy, it is just very small. And then after the surgery, we put it back with 2 titanium plates with screws. And the cosmesis is fantastic. So why do we remove the orbital rim for some cases? Because imagine, without removing the orbital rim, when we put an endoscope here and some instruments here, the globe needs to be displaced or a bit retraction medially. However, if we remove the orbital rim here, as depicted by orange here, then the space is much wider. So sometimes we do remove the orbital rim, but depends on cases. So the next step after the skin opening, then what do we do? There is a periorbiter, that is the covering the globe and also the orbital content with the orbital fat. We protect the periorbiter and keep it intact. We first medialize the periorbiter until we reach a structure called the meningo-orbital band. Okay, and then we divide it, and then we continue to strip medially and posteriorly. Then we can see the superior orbital fissure and also the inferior orbital fissure. And here, this region, it corresponds to the lateral orbital wall, which is actually on the other side, from the cranial side. It would be the greater wing of the sphenoid. Okay, so this is the other side as viewed from in front. Because for neurosurgeons, we usually view it from above. Now we view it from anterior and a bit inferiorly. So after drilling off the greater wing of sphenoid, we will see this. This is a temporal dura, the middle fossa dura. Here is the SOF, and above the sphenoid ridge. And then if we go inferiorly, we will reach the inferior aspect of the middle fossa, that is the base of the middle fossa dura. We continue to lift it up, we peel it, and then we can reach the middle fossa floor. During the drilling, we use a diamond burr with self-irrigation because to clear the vision and to maintain bloodless field. So as I mentioned, the extradural dissection through the meningo-orbital band is key to unlock the periorbiter from the dura. Just like from above, when we do a craniotomy, we have to cut the meningo-orbital band, then we continue to go all the way to the anterior canal process. This is the way we do it from below. So it's kind of similar. So step 3 is the extradural dissection. We peel off the lateral wall of the cavernous sinus. To see that this is the periorbital and this is the temporal dura, we continue to peel it all the way posteriorly, and then we will reach this view. This is a fantastic view of the Makos cave here. And then these are the cranial nerves that you can see. This is the anterior cranial process. This is the third nerve, the fourth nerve, the V1, the V2, and the V3. And this is the anteromedial triangle between the V1 and V2, and this is the anterolateral triangle between the V2 and V3. Here is the foramen rotundum, and here is the foramen ovale. And if we further open the lateral wall of the cavernous sinus between the V1 and V2 angle, that is the anteromedial triangle, then we will see the structure within the cavernous sinus, namely the ICA here, and then the sixth nerve, and all posteriorly we can see the Doretto's canal here with the endoscope. And here is the parakyphal segment of the carotid artery as well. Next, if we drill the anterolateral triangle between the V2 and the V3, we see this view. Here is the sphenosinus, which, if we go from the nose, then if we drill through the same triangle, we'll be able to see this area. So imagine the scope is coming from here, from the sphenosinus, from endonasally. And here we are taking this view from the lateral window. So here is the lateral segment of the ICA. This is the petrous segment of the ICA. This is a videal nerve, the eustachian tube, the lateral pterygoid plate, and the sphenopalatine artery. So it might be a bit hard to imagine if you it's the first time if you ever heard of this approach. So this should be more familiar. This is the classical view of the Makos cave, the V1, V2, V3. This is the anterior cranial process, and this is the tentorial edge. So this view is like this. We just flip, turn around 90 degrees, and then here is what you see. So this is really a direct and anterior approach to the deep skull-base structures without creating a large opening, without creating a lot of mobility and bone drilling, and it saves time to reach this structure. And even more posterior dissection, we can reach the calvitis triangle, which is the petrous apex. Here is the GSPN, the LSPN, the MMA, and this is where the petrous segment of the carotid artery is. And if we go medially, we can also reach the optic nerve. Here is the frontal dura, the temporal dura, and the periorbital. So here we see the anterior canal process. And then if we drill this off, we will be able to see the optic nerve from above. Okay, and this is the optic struct. And if we remove the optic struct, here is the carotid artery and the third nerve. So all this was done in the lab. So if you are interested in this approach, I really highly recommend that you need to study in the lab first before ever considering practicing in human patients, because it is quite an unfamiliar approach for neurosurgeons. So next, we open the frontal temporal dura. We'll be able to see this fantastic view, the fantastic view. Look here, this is the frontal lobe, this is the temporal lobe, this is the MCA, the M1, the M2, this is the insula, and here is the A1. And we can see the branches of the M2. And if we put the endoscope medially, we'll be able to see the stalk, the pituitary stalk, the optic nerve, A1, PCOM, and the ICA. And what's more, with this direct and anterior view, because the window is actually quite large when compared to endonasal approach. For endonasal approach, if we want to reach here, probably we need around 7 to 8 centimeters from the nose to reach here, and which makes suturing very difficult. But then for this, for the endoscopic transorbital approach, the distance is quite short. It's just around 4 centimeters to 5 centimeters. So primary dural suturing is also feasible in cadavers. So after all these cadaveric dissections, so are these clinically applicable? So there are different publications that have been available, which suggest different indications. For example, sphenoorbital meningiomas over the sphenoid ridge, lesions at the lateral wall of the cavity in the sinus, even temporal lobe lesions for gliomas, and some frontal basal gliomas, sphenoorbital meningiomas again, and optic sheath meningiomas are potential applications for this approach. So since 2017, there have been different authors publishing their small case series, like here from sphenoorbital meningiomas to cranioorbital tumors to Makos cave tumor schwannomas, and they are reported to be safe and feasible, and gross total resection technically be done. So these are some more recent publications talking about a combined and simultaneous endoscopic endonasal and transorbital surgery that is a biportal approach using both the endonasal and the transorbital port to tackle Makos cave schwannoma. Actually, I have a case that will be done soon with this approach. And this Korean group, a South Korean group, has also published their experience with clinical application of the endoscopic transorbital approach for various lesions. So you can see there are a lot of different tumors here. By some strict criteria and selected criteria, this transorbital approach can be used. So again, why we use tones? Just to recap. So video-assisted magnified view is possible. Otherwise, it is a very confined space. With a microscope, on the other hand, it's not possible. It's a direct anterior approach and offer good working angles. And two surgeons can work comfortably in a coplanar manner, like this, to address the lesion with increased ease of forehand operation. And it also avoids crossing some critical neurovascular structures, for example, carotid artery, cranial nerves in the cavernous sinus, in contrast to extended endonasal transpterygoid approach, for example, and the short working distance, as mentioned, when compared to the extended endonasal approach. So the advantage over craniotomy is that it offers a very small incision, or sometimes even is a scarless incision, less invasive and less surgical mobility, much less blood loss, no brain retraction, as you can see. It's mainly the work within the orbit, and a lot of times there is minimal effect to the ocular movement, and there's no problem with the vision, because we use a dynamic retraction. We don't pull the globe very hard. We just dynamically retract, and from time to time, we will release the retractor to check the pupil to make sure that everything is fine. And with all the case reports, case series that have been reported in the literature so far, there have been minimal mobility to the globe. So it's a safe approach. But of course, you need expertise, and to reiterate, you need a good team with ophthalmologists to start off with. And the advantage also includes avoid bifrontal craniotomies, no exposure of the frontal air sinus or the sagittal sinus, and it avoids injury to the supraorbital nerve, to avoid numbness, and avoid atrophy to the temporalis muscle, and also to avoid injury to the facial nerve as well. So now let me talk about some cases that we have done in our hospital. So this is a case that is a lady with a orbital, with a sphenoorbital and meningiomas here, okay, and with quite a significant hyperostosis here. So traditionally, we need to do a craniotomy to remove this lesion, okay? But then with this approach, we don't need to do so. So this is what we have done. So it's a phenol-rich meningioma presented with right eye proptosis and blurring of vision. And there is a poor visual acuity. And you see that the eye is proptotic here. Skip this. So this is where the meningioma is, and it's mainly the hyperostosis that is worrying the patient. So this is the scar of the craniotomy if it's needed, but with the transorbital approach, the incision is just over the eyelid. So we do incision over the superior lid crease, and then we expose the lateral orbital rim, and we dissect the periorbita here. And then a surgical corridor has been created. And here we put in the endoscope through the right eye, through the right orbit, I mean. So here we can see that this area is the hypertrophied bone, hyperostosis. So we retract the periorbita medially and protect it with a retractor. And then we use a diamond drill. Here first we use a cutting burt, and then we switch a diamond drill to remove the hyperostosis here. And then further on, we remove the medial wall of the hyperostosis. And then we see the meningioma here after opening up the dura. And then the tumor is removed with suction and the forceps. And see the brain here, and this is the meningioma. And then to achieve a symptom 1 removal, we also remove the dura. And then we just use the Surgicel for hemostasis, and we put a dermis fat graft for repair the dura defect. And we put a dura substitute as well. And then finally, with a fibrin glue to seal it off. So we check the pupil after the end of surgery. And you see this is a pre-op and this is post-op. And the hyperostosis has been removed and the proptosis has been resolved, and the vision also improved. So the proptosis removed with a gross total resection of the meningioma being possible. And you see the extraocular eye movement is very good. So we next, for this case, this is a lady with orbital apex cavernous venous malformation located here. This lesion is not very big, but then it causes quite a lot of pressure to the optic nerve, and it causes a visual impairment. So again, patient with a right blurring of vision here. This is the preoperative MRI. You see the lesion here over the orbital apex. Again, we use a superior lid crease incision and then protect the periorbita with a handheld malleable retractor. We remove the right orbital rim in this case because we want to have more space for manipulation and dissection. And for this case, we also use an ICG endoscope, indocyanine green endoscope. So we divide the first we divide the meningeal orbital band. We cut it here, and then to unlock the periorbita from the skull base. And then we drill the greater wing of sphenoid here. And then we see the middle fossa dura again. Notice that there is a copious irrigation during the drilling. So there are two folds. One is to keep the vision clear, and also because with a diamond drill, there is a lot of heat generation. So with the drilling, it is very important, especially with drilling just next to the globe and also near the optic nerve. So we open up the periorbita here medially, and then we inject the indocyanine green. So we inject it via the intravenous approach by the anesthetist. And then you see that here, this is the lateral rectus muscle that lights up first. And then here, the cavernous hemangioma is identified by delayed filling of around 1 minute later. Because this is a venous phase of hemangioma of a vascular malformation, so the filling is slower later than the muscle. So with the aid of the ICG endoscope, we are able to identify the cavernous hemangioma. Otherwise, you may be able to appreciate that it is actually quite difficult to differentiate from the surrounding muscles. They may look similar, they look a bit reddish. So we dissect the lesion away from the orbital apex, and then we remove the lesion in one piece en bloc. So this is the lesion, and this is postoperative CT, which shows the lesion has been removed. And the here is the orbital rim that has been played back. So the vision improved, and the RAPD has been resolved, and the extraocular eye movement is full, and very good cosmetic outcome. We've also done a case of orbital. This is a case of orbital schwannoma with similar approach using a endoscopic approach. But then for this, our incision is over the subbrow here. Okay, subbrow incision. And then because this patient is wearing spectacles, and it is beautifully obscured by the spectacles cosmetically, just a very small scar. And it will go away with time as well. So this is another case of infratemporal fossa recurrent pituitary tumor over the right side here. This is a very invasive pituitary tumor with endonasal surgery done endoscopically a few years ago. However, it recurred laterally to the infratemporal fossa and around the orbital apex. So as you can see, it's very difficult to reach from the endonasal approach. If we really need to tackle it traditionally, either we do a transorbital approach, but still it's difficult to do a very good excision, or we need to resort to a craniotomy, which may not worth the case because it is relatively less symptomatic. So we approach this residual recurrent tumor here with a transorbital approach. They do a subbrow incision. So again, this is a dissecting of the periorbita from the orbital wall. This is a drilling of the sphenoid wing until the middle fossa dura is reached. Again, we're drilling under irrigation. And we debug the tumor with suction. And with forceps with a rhongia, small rhongias, and we dissect the tumor from the V3. So here, this is the middle fossa dura, and this is the V3. It is being kind of invaded and surrounded by the tumor. So we use a suction, it's a soft tumor, to remove the tumor around and behind the V3, which would not be possible if we do it using the craniotomy approach or the endonasal approach. So this is the V2 medially. This is a V3, very clearly dissected out. So this is towards the end of the surgery. You see it's very clear view, and it basically doesn't require a lot of hemostasis. We just use saline to irrigate, and then we put in Surgisil for hemostasis, just to make sure, and then Surgisil again, and we put in fibrin glue, and that's it. So this is the cosmetic outcome of this patient. The left side is a very early post-op. You can still see the stitches. So, but there is not much eye swelling, and the vision is good. It's better than pre-op. And this is around 3 weeks after operation, after follow-up. There's a faint scar here, and it will go with time as well. And the last case I will show, this is a case of nasopharyngeal carcinoma with a radiotherapy done before, and then with the patient presented with V3 numbness over the right side, and this is the MRI showing there's a normal signal over the infratemporal fossa. So the aim is to do a biopsy of this region, which would be difficult through the endonasal approach. And it's quite deep-seated, so we use the transorbital approach through the foramen ovale. So this case for the incision, we use a swinging eyelid incision and do a transconjunctival approach. We identify the inferior orbital fissure, so we go a bit lower to reach the infratemporal fossa. And then we drill the sphenoid wing, greater wing of sphenoid, with again the diamond burr with the irrigation. The middle fossa is seen and then elevated. The drilling continued till the V3 is reached. And then we open up here along the V3. And then we open up the periosteum of the infratemporal fossa. We take a biopsy in multiple sites. And we are able to also see the IMAX, the internal maxillary artery here over the infratemporal fossa. So this is quite a good approach to the infratemporal fossa. Otherwise, it is actually in a no man's zone, I would say, because either we need a big craniotomy to reach there with a zygomatic incision, a lot of dissection, or even some mid-phase approach, which would be undesirable for the patient. So again, very early post-op for this patient, but then you see the cosmesis is already quite nice. So I would like to also take this opportunity to thank my team, my colleagues in the Queen Elizabeth Hospital, and the ophthalmology team, Professor Hunter Yun from Hong Kong Eye Hospital, a very renowned international oculoplastic surgeon, to help with the approach and also throughout the surgery. And special thanks to Professor Sebastian Frolisch from Hospital Hippozyerk in Paris, which I've spent some time with him, and it's him who inspired me with this approach. And my two Korean friends, Dr. Kong and Park, good friends of mine who gave me advice when I started this operation in Hong Kong. So in summary, to conclude, endoscopic transorbital surgery is an emerging minimally invasive surgical technique in the orbital apex. And it's also applicable to some skull-based pathologies located lateral to the cavernous sinus and also at the infratemporal fossa. It is a direct and anterior approach when compared to craniotomy or to endoscopic endonasal approach. However, training and dissection in the lab, I would say, is very useful and if not mandatory. And to start this, you need a good collaboration with neurosurgeons and oculoplastic surgeons. So this is my city, Hong Kong. So hope after COVID, you would like to visit Hong Kong, and Hong Kong would welcome you as always. Thank you.
Thank you so much, Dr. Calvin, for your presentation. Such an honor to have a great neurosurgeons with us, like you with us. We have a couple of questions. First question is if these procedures, these endoscopic procedures, can be used for treating also intracavernous pathologies.
Yes, definitely. I think for intracavernous pathology, you mean lesions at the cavernous sinus, right?
Yeah.
Yes. Well, for the cavernous sinus, there are different compartments, as you may know. And so just to make things simple, either lateral compartment or the medial compartment. So for the lesions that is medial to the ICA, I would say endoscopic endonasal approach or a traditional craniotomy would be a good option. For lesion that is over lateral to the ICA and the lateral compartment of the cavernous sinus, the endoscopic transorbital approach is fantastic because, as you can recall, the eye is actually located lateral to the nose, right? And this is where the carotid is. So this approach by putting endoscope lateral to the carotid artery is quite an intuitive way to tackle with lesions over the cavernous sinus. However, you need good skills, a good team. You have to have good experience with first endoscopic endonasal approach first before you can attempt endoscopic transorbital approach.
Thank you so much for your answer, Doctor. Diego, would you like to ask something?
Yes. Well, first, thank you very much, Dr. Calvin Mak, for the wonderful presentation. It's very interesting to acknowledge this particular endoscopic approach. And well, the question is about surgery corridors that are more like suitable for accessing the anterior and medial cranial fossa. Are there any like particular studies or papers, anatomical papers, for which surgical corridor is best or is better suited for reaching these particular sections?
So, well, I think you mean for endoscopic transorbital approach. So yes, there are indeed quite a number of good anatomical studies from different groups. I think the literature has been available since 2016 or 17. There are a lot of papers nowadays. So yes, definitely there are some anatomical studies, and our group is going to publish some studies as well, especially to the infratemporal fossa, which we think it's a fantastic way to do it as well.
Okay, and the last question is about well, within this context in the COVID pandemic, has something changed in the approach of skull-based pathologies between endoscopic endonasal approach and minimal invasive transciliary or transorbital approach?
Yes, well, I think in general, I think COVID is affecting all the world. So elective neurosurgery operations, if they're not life-threatening, probably they have been delayed. But well, we're lucky in Hong Kong, we are kind of almost resuming our services right now. I hope it's also like this over Mexico or other parts of the world. And but in like last year, we were a bit concerned. We have been quite concerned about the endoscopic endonasal approach. We take extra precautions. We take 2 COVID tests for patients, and we use the precautions to avoid, to minimize the use of the high-speed drills, because drill can cause aerosols generation in the operation theater. We try to limit that. But then for transorbital approach, it is another story, because it's not involving the nasal mucosa, so it's not the upper respiratory tract that we think the viral load would be highest. So the transorbital approach is, I would say, is probably less a threat in terms of COVID than an endonasal approach. So for craniotomy, we just take usual standard precautions like other surgeries, in general surgery or in other orthopedics, etc. But as you know, brain surgeries, we cannot wait. It's usually life-threatening, so we just take extra precautions.
Thank you very much again for the answers, Doctor.
Welcome.
Thank you, Doctor. On behalf of the Sign Mexico group and of the Walter Dandy Society, we thank you again, and we hope to see you soon there in Hong Kong or here in Mexico. Thank you, Doctor.
Thank you. Thank you. Thank you very much.